Every single morning, somewhere around 70 million Americans swallow a tiny white pill. They don't think twice about it. Their doctor told them it was safe. The internet says it's one of the most prescribed medications in the world. And so they take it, day after day, year after year, without ever asking what's actually happening inside their body while they sleep. But here's what almost no one tells you. After 5 years on this drug, 5 years of trusting it, 5 years of it running silently through your bloodstream, something begins to shift. Not dramatically, not in a way that shows up on a simple blood test, but deep inside your cells, inside your blood vessels, inside the very biology of how your heart regulates itself, something changes. And researchers are only now beginning to understand what that something actually is. The pill is called amlodipine, and this is the story of what it really does to your body after years of use, told from the inside out. If this is the kind of video that makes you think twice about what you're putting in your body every day, go ahead and hit that like button now. And if you want more content like this, things your doctor might not take the time to explain, subscribe to this channel, because we're just getting started. To understand what amlodipine actually does, you first need to understand the problem it was invented to solve. Picture your arteries for a moment. Not as tubes. Think of them as living, breathing, muscular corridors. They're not passive. They squeeze and relax constantly, adjusting blood pressure in real time, responding to stress, emotion, movement, temperature. They're dynamic, alive, but for roughly 1 in 3 American adults, those corridors are too tight. The muscles in the artery walls are contracting too hard, too often. Blood pressure climbs. The heart has to pump harder just to push blood through. Over time, that constant pressure damages the walls of blood vessels. It strains the heart. It silently increases the risk of stroke, heart attack, kidney failure. This is hypertension. And for decades, doctors struggled to find something that could safely relax those artery walls without causing serious side effects. Then, in the 1980s, a new class of drugs emerged. They were called calcium channel blockers, and amlodipine, introduced in 1990, became the star of that class. The idea was elegant in its simplicity. Calcium is what tells muscle cells to contract. Block the calcium from entering those cells, and the muscles relax. The arteries open. Blood flows more easily. Pressure drops. It worked. Brilliantly. Clinical trials showed it reduced heart attack risk, reduced stroke, improved quality of life. It was hailed as one of the most important cardiovascular drugs ever created. And for short-term use, that reputation is absolutely deserved. But here's where things start to get complicated. The question scientists never fully asked, at least not publicly, not loudly, was this: what happens when you block calcium channels not for weeks, but for years? What happens when you do that for a decade? Because calcium isn't just involved in muscle contraction. Calcium is a messenger. It's one of the most fundamental signaling molecules in the human body. It tells cells when to divide, when to die, when to repair themselves, when to communicate with neighboring cells. Calcium is involved in bone remodeling, in nerve signaling, in immune function, in the regulation of gene expression itself. So when you introduce a drug that systemically alters how calcium moves through cells, not just in your arteries, but throughout your entire body, you are, in a very real sense, changing the conversation your cells are having with each other. Every single day. For years. And some researchers have started asking, what does that mean in the long run? What they found is unsettling. Not because it means amlodipine is a poison, it's not, but because the picture that emerges is far more complicated than the simple, relax the arteries story most patients are told. Let's start with something most people never hear about: what amlodipine does to your gums. This sounds small, almost trivial compared to blood pressure and heart disease. But stay with me, because this side effect is actually a window into something much bigger. After months or years on amlodipine, somewhere between 10 and 20% of patients develop a condition called gingival hyperplasia. Their gums begin to overgrow. The tissue thickens. In some cases, it grows over the teeth. It causes pain, bleeding, difficulty eating. Sometimes it requires surgery. Now, why would a blood pressure pill affect your gums? Because amlodipine doesn't just affect calcium channels in your arteries. It affects them in the fibroblasts, the cells responsible for producing and maintaining connective tissue throughout your body. When those cells can't regulate calcium properly, they start overproducing collagen. The tissue grows, it swells. And here's the thing that should make you pause. Your gums are just the most visible place this happens. Connective tissue is everywhere. It's in your joints, your organs, your skin. The scaffolding of your entire body is made of connective tissue. So when a drug alters the calcium signaling in the cells that build and regulate that scaffolding, what is it doing to the rest of you? Quietly. Over 5 years? Over 10? The honest answer is, we don't fully know. And that uncertainty is the beginning of the real story. Now let's go deeper. Because the long-term effects on the cardiovascular system itself are where things get truly fascinating and disturbing in equal measure. Here is a paradox that cardiologists have wrestled with for years. Amlodipine lowers blood pressure. Lowering blood pressure reduces the mechanical stress on artery walls. That should mean the arteries get healthier over time, right? Sometimes, but sometimes not. Here's what researchers discovered in long-term studies that most people have never read. After years of calcium channel blockade, the smooth muscle cells in artery walls begin to undergo something called phenotypic switching. They change. Not all of them, not permanently, but in a measurable way. Those smooth muscle cells are supposed to be contractile. Their whole job is to squeeze and relax to regulate blood pressure. But under prolonged calcium channel blockade, some of them start behaving more like synthetic cells. Instead of contracting, they start secreting proteins. They start depositing material into the artery wall itself. In some cases, researchers have observed increased calcification of arterial tissue in long-term users. Wait, read that again. A drug designed to block calcium in the arteries, associated in some studies with increased calcium deposits in the arteries over the long term. The biological irony is almost poetic. And this is not a fringe theory. Studies published in journals like Hypertension and the Journal of the American College of Cardiology have documented higher rates of coronary artery calcification in certain patient populations on long-term calcium channel blockers. The mechanism is complex, debated, and still being studied. But the signal is there. And this is where everything starts to get much, much bigger. Let's talk about your kidneys. Because amlodipine was actually considered a protective drug for kidney function, especially in diabetic patients. And in many ways, it still is. By reducing blood pressure, it reduces the strain on the delicate filtration system inside the kidneys. But here's what often isn't discussed. Amlodipine dilates the blood vessels entering the kidneys, the afferent arterioles, more aggressively than the vessels leaving them. This creates a specific pressure dynamic inside the kidney's filtration units. For most patients with high blood pressure, this is actually fine. The net effect is protective. But in certain patients, particularly those with specific types of kidney disease, those who are already experiencing reduced kidney function, this pressure imbalance can accelerate damage over time. The question is, how many patients on long-term amlodipine therapy actually fall into that category and don't know it? How many people are taking a drug that was prescribed to protect their kidneys, not realizing that their specific kidney physiology might make them one of the exceptions? This isn't a reason to stop taking the medication. This is a reason to monitor, to ask questions, to not assume that because something is safe for most people, it is safe for you specifically, indefinitely. But here's where things get even darker. There is a phenomenon that almost no one outside of cardiology research talks about. And it has to do with something called sympathetic rebound. When amlodipine lowers your blood pressure by relaxing your artery walls, your nervous system notices. It registers a drop in pressure. And your nervous system does not like that. It responds by increasing sympathetic nervous system activity, essentially turning up the body's internal alarm system to compensate. Your heart rate can creep up. Hormones like norepinephrine are released in slightly higher quantities. Your body tries to counteract the drug's effects. Over time, this can create a state where your body is simultaneously being chemically relaxed by the medication and being physiologically stressed by the nervous system's counter-response. Now think about what chronic sympathetic activation does to a human body. It's the same cascade that stress triggers: elevated cortisol, inflammatory signaling, disrupted sleep architecture, immune dysregulation. Over months, over years, the downstream effects of that chronic low-level activation are not nothing. And this might explain something that doctors have noticed anecdotally for decades, but struggle to prove mechanistically. Some long-term amlodipine patients develop a kind of fatigue that seems disproportionate to their other health conditions. A brain fog. An emotional flatness that they sometimes attribute to aging, or to stress, or to their blood pressure condition itself, when in fact it may be, at least in part, a consequence of years of this pharmacological tug-of-war between the drug and the nervous system. But here's the twist that researchers didn't expect, and the one that changes the entire narrative of this video. Despite all of this, despite the gum changes, the arterial remodeling questions, the kidney pressure dynamics, the sympathetic rebound, amlodipine still saves lives. Clearly, measurably, powerfully. The large-scale ALL-HAT trial, one of the most important hypertension studies ever conducted, involving over 33,000 patients, showed that amlodipine was as effective as, and in some outcomes better than, other antihypertensive drug classes in reducing major cardiovascular events. The data is real. The benefit is real. So this is not a video telling you to stop taking your medication. This is a video about something far more important than that. This is a video about the gap between "this drug is safe and effective" and "we fully understand everything this drug does to your body over 10, 15, 20 years of continuous use." Those are two very different statements, and in the world of medicine, they are often treated as if they are the same statement. And that gap, that space between proven benefit and unknown long-term biology, is where the most important questions live. There's a concept in pharmacology called the therapeutic relationship. The idea that a drug doesn't just treat a disease. It enters into a long-term biological conversation with your body. Your body adapts. Your cells change their behavior. Your receptors upregulate or downregulate in response to constant chemical signals. Your organ systems remodel themselves around the new chemical reality. And here is the profound thing about amlodipine specifically. It has an extraordinarily long half-life. Most blood pressure medications are in and out of your system within hours. Amlodipine stays. It accumulates in tissue. Its half-life is between 35 and 50 hours. That means it's never really gone. Day after day, year after year, it is always present, always whispering to your calcium channels, always slightly reshaping the conversation your cells are having. For 70 million people, this is just Tuesday morning. Another little white pill. A routine so automatic they could do it with their eyes closed. But somewhere deep inside their bodies, in the smooth muscle cells of arteries, in the fibroblasts of connective tissue, in the filtration units of kidneys, in the neurons of the autonomic nervous system, conversations are happening. Adaptations are being made. Biological compromises are being negotiated between what the body was designed to do and what the chemistry is telling it to do instead. And after 5 years? After 10? After 15? The question isn't whether the drug is working. It clearly is. The question is, what does the body look like on the other side of all that negotiation? This is the part of the story where we have to talk about what gets lost in the silence between doctor visits. Most patients on long-term amlodipine therapy see their doctor, get a blood pressure reading, hear "looks good," and leave. Blood pressure is controlled. Mission accomplished. But blood pressure is one number, one data point. It tells you almost nothing about what's happening in the arterial walls. Nothing about the state of the autonomic nervous system. Nothing about connective tissue health, gingival changes, renal pressure dynamics, or the slowly accumulating calcium deposits that may or may not be forming in vessels throughout the body. The annual checkup, as it exists for most Americans, is not designed to detect the long-term biological adaptations to chronic drug therapy. It was never designed for that. And so those adaptations, whatever they are, beneficial or otherwise, happen in a kind of clinical darkness, unseen, unmeasured, unnamed. This is not a failure of medicine. Medicine has saved millions of lives with amlodipine. This is a failure of the narrative we tell about medicine. The story that says, take the pill, the number goes down, you're safe, stop thinking about it. That story is incomplete. And incomplete stories are how we sleepwalk into consequences we didn't see coming. Now I want to ask you something directly, and I want you to actually think about this. If you are on amlodipine, or if someone you love is, when was the last time anyone actually asked about more than the blood pressure number? When was the last time someone asked, how are your energy levels? How's your sleep? Have you noticed any changes in your gums? Any joint stiffness, unusual fatigue, swelling in the ankles that you've been chalking up to aging? Ankle edema, swelling in the feet and lower legs, is actually one of the most common side effects of amlodipine, affecting up to 10 to 15% of users, and it tends to worsen with time and dose. Many patients live with it for years, assuming it's just a consequence of getting older. Some are prescribed diuretics to manage the swelling, adding a second drug to manage a side effect of the first, without ever questioning whether the swelling itself is trying to tell them something. The body is always communicating. The swollen ankle is a message. The fatigue is a message. The gum changes are a message. And the tragedy is that in a 10-minute appointment, those messages rarely get decoded. Leave me a comment right now. How long have you or someone you know been on amlodipine? Has anyone ever had this kind of conversation with their doctor? I genuinely want to know what your experience has been, because the gap between what happens in clinical trials and what happens in real people's lives is enormous, and your story matters. Here's where the science gets almost philosophical. Because what we're really talking about when we talk about long-term drug use isn't just chemistry, it's identity. Your body at this moment is not the same body you had 5 years ago. Almost every cell has been replaced. Your arteries have rebuilt themselves thousands of times. Your immune cells have lived and died and been reborn. The physical substance of you is in a constant state of renewal, but amlodipine has been present through all of that renewal. It has been there during every rebuild, every repair, every adaptation. And biology doesn't rebuild in a vacuum. It rebuilds in response to the chemical environment it finds itself in, which means that for a long-term user, some of those rebuilds have happened in the constant presence of calcium channel blockade. Some researchers have asked whether this changes the baseline biology, whether after a decade of amlodipine, your cardiovascular system has developed a kind of dependency on the drug's presence, not in an addictive sense, but in a physiological one. Whether the system has recalibrated itself around the drug being there, such that its sudden removal would trigger a violent rebound of blood pressure and sympathetic activation. The answer, in many cases, appears to be yes. This is why you should never stop amlodipine abruptly without medical supervision. The body has adapted. Withdrawal is a real phenomenon. The very success of the drug at reshaping cardiovascular physiology means that the cardiovascular system has, over years, come to expect it. You are, in a real biological sense, not quite the same organism you were before the drug. Your body has incorporated the drug's presence into its operating system. Let that sit for a moment. And this brings us to perhaps the deepest question of all, the one that goes beyond pharmacology and enters the territory of how we think about chronic treatment in modern medicine. We are living in the era of the forever drug, the medication you start in your 40s and take every single day until you die. Statins, blood pressure pills, antidepressants, metformin, the list grows every year. And for each of these drugs, the research that established their safety was done over years, not decades. Over controlled trials, not the messy, complicated, co-medicated reality of an aging human body taking 4, 5, 6 medications simultaneously for 20 years. We are, in a very real sense, the first generation of humans to live out the full, long-term biological consequences of these pharmacological interventions. The data doesn't fully exist yet. We are the data. And amlodipine, for all its genuine benefits, is perhaps the clearest example of this phenomenon. It works beautifully. The short-term evidence is overwhelming, but the 20-year story, the whole body, whole life story of what it means to have your calcium channels gently blocked every single day from 45 to 75. That story is still being written by the bodies of 70 million people who mostly don't know they're writing it. So what should you actually do with this information? Because this video would be irresponsible if it simply frightened you and left you there. First, do not stop taking your medication based on anything you heard here. High blood pressure is a silent killer. The risks of uncontrolled hypertension are documented, severe, and immediate. Amlodipine has saved more lives than the long-term questions have cost. That is the honest truth. But here's what you can do. You can become an informed participant in your own care. You can ask your doctor about your coronary artery calcium score, a simple, inexpensive CT scan that can actually visualize calcification in your arteries and give you a baseline. You can ask about your kidney function in more detail than the standard annual panel. You can report the ankle swelling, the fatigue, the gum changes, and ask whether they're being monitored. You can ask whether your dose is the lowest effective dose, whether lifestyle changes have been explored aggressively enough to potentially reduce that dose over time, whether a different class of antihypertensive might offer a comparable blood pressure benefit with a different long-term biological profile for your specific body. These are not radical questions. They are the questions an informed, engaged patient is entitled to ask. And a good doctor will welcome them. Because here is the final truth, the one that this whole story has been building toward. Medicine is not a transaction. It is not, here is a problem, here is a pill, problem solved. Medicine, at its deepest level, is a negotiation between the complexity of a living human body and the blunt instruments we have invented to nudge it toward health. Those instruments are remarkable. The fact that we can take a tiny pill and reduce a person's stroke risk by 30% is nothing short of miraculous. And that miracle deserves to be honored. But a miracle is not a blank check. The body that is being nudged is not a simple machine. It is 37 trillion cells in constant conversation. It is a system that has been evolving for hundreds of thousands of years to maintain its own balance, its own equilibrium, its own wisdom about how to stay alive. When we interrupt that system, even with the best intentions, even with clear benefit, we need to stay curious. We need to keep asking. We need to never let the comfort of a controlled blood pressure number become an excuse to stop paying attention to everything else. Because the body is always paying attention. The cells are always adapting. The biology is always responding. And somewhere in the smooth muscle walls of 70 million arteries, in the connective tissue of 70 million mouths, in the autonomic nervous systems of 70 million human beings going about their lives, a long, slow, quiet conversation is happening. A conversation that began the moment they swallowed that first little white pill. And the question is not whether that conversation is happening. It is. The question is whether anyone is listening. If this video made you think differently about what you put in your body, or about how we talk about medicine in general, share it with someone who needs to hear it. Because the most important health conversations aren't happening in hospitals. They're happening between people who care about each other. And if you want to keep going deeper on the things your body is doing that no one is explaining clearly, subscribe to this channel. Dr. Victoria Reed is here every week, turning the hidden science of your health into something you can actually understand. The next video might change how you think about something you've been trusting for years. Don't miss it.